Looks like it's going forward on me. Restraint and seclusion has been happening in US institutions for a very long time. It's actually like part of the, if you've ever been part of like a history of the mental health movement workshop, or history of the mental health system workshop in prior years, you probably have heard about some of the really egregious things that have happened throughout our history to people who are institutionalized. And what we see today is that restraint and seclusion are still actively being practiced in several of our nation's institutions. And here we focused on schools, psychiatric institutions for youth, psychiatric institutions for adults, nursing homes, and then we had a category called other. So I'll tell you more about that as we go through the presentation. But what I kind of want to say here to sort of set the stage is that this has been going on for hundreds of years, really longer than that, and that it continues today. And so there's still more to be seen. Really, this is a practice that's quite hidden unless, you know, for those of us who've either worked or been inside of these institutions when these things were going on, the general public may not, it likely isn't on people's radar at all, because it really happens in the confines of, you know, inside the walls of these institutions. So part of my motivation is just to bring some of that to light, and also just to have more active conversations about the more egregious things that are still happening inside of these institutions, and just talk about what that experience is like, and really what it's like on both sides of the coin. You'll see in the survey responses that we had some really, really interesting information from both staff and people with lived experience. So I'm excited to share this with you all. So I'm Patricia Godsey. I have been part of the consumer survivor ex-patient movement for 10 years now. Maybe it's getting closer to 11. Right now, I am in a master's program for social work through PSU. So I kind of did advocacy work for, you know, just under a decade, and then decided that I was going to go back to school. And so I'm at PSU. I have 1 year left. And this last year, my second year of the program, I was interning with the National Coalition for Mental Health Recovery. And I had been introduced to the coalition through alternatives, actually. So maybe I've been to a handful of alternatives conferences, 5 or 6. And every time I would go, I would make sure to attend that annual meeting, which this year's was actually last night at Peerpocalypse, because alternatives and Peerpocalypse this year have kind of joined forces. So I was introduced to the coalition through conferences, and had the opportunity to work with them over the last year. And so the main thing that I did during my time as an intern is create this project around seclusion and restraint. So part of the way that this came to be was because of my interest in the topic of seclusion and restraint, and how that aligned with NCMHR's policy priorities. So there, at the time that I was first interning and carries through today, there's a policy priority around protecting and promoting human rights, especially of Americans diagnosed with mental health related conditions. And a sub goal in that category is ending involuntary treatment and coercive treatments. And so the practice of seclusion and restraint really falls into that category of coercive treatments. So that kind of set the stage for this work. And then what we did is develop a steering committee that was made up of people with lived experience of having been secluded or restrained themselves, and people who worked in places where seclusion and restraint are used. So there was a steering committee formed. I, as kind of the lead researcher, spoke with each steering committee member individually about the project, my ideas about it, and just about their experiences regarding seclusion and restraint. And then I drafted some survey questions based on what I heard from these experiences. And those questions were then translated into Spanish as well, so that we could increase the accessibility of the survey. We distributed the surveys to the consumer survivor ex-patient community and also people in groups who we knew were working in the settings that we were discussing in the survey. So we distributed the survey. The survey was out for a couple of months. We got tons of responses, which was really just so exciting. I was really humbled by the responses. You'll see, you'll see the information that we got, and people were really genuine and really like honest and vulnerable in these responses, which I know is a really difficult thing when, when it's a topic that has touched our lives so deeply and had such a profound impact on us. So just really, I was humbled and overwhelmed by the response. And if any of you who are in this webinar participated in the survey, I want to say like a really heartfelt thank you to you. This work is really important, and so thank you for trusting me and the coalition with your responses. So after that information all came in, I went through and analyzed it. I was looking for themes, and there was a combination of kind of yes, no, I don't know kind of questions, which you'll see some answers to in a little bit, and also some open-ended responses so people could type in and talk to us about the experience. So I went through all of those and just and categorized some of the responses to see if there were things that emerged that several people were saying, or that we could pull out as kind of overarching. And so you'll see in this presentation several themes that came out of that work. And then we created a draft of recommendations that could come out of this work based on what people told us. And in May, we did a webinar kind of first presenting this information to the world and getting feedback on those recommendations. So there were over 100, like somewhere between 100 and 130 people on that webinar. And so there was an opportunity for that entire group to give feedback. And then after that webinar, I kind of distilled the feedback. And so in this presentation is the first time that that kind of the world will see the final recommendations. And then attached to this presentation, so we'll kind of go through what I'm talking about here in more depth. And attached to this presentation, you'll see one PDF that has kind of a synopsis of the findings of the research. And then you'll also see a second PDF where the first page is a form letter that can go to legislators, policymakers, administrators, people who have the ability to impact change. And it's just a form letter, and you can kind of put in your name and your information and then the person's name that you're sending it to. So please feel free to use both of those. And yeah, I'll tell you what we kind of found. So first, a huge thank you to the steering committee. This group of people was so fantastic, and really, I couldn't have done the work without this group. I bounced ideas off of everyone. Everyone contributed something really substantial. So thank you to everyone on this list. And let's see, I know for sure that Cindy Daniels is in this workshop. So thank you, Cindy. Cindy was a huge sounding board and just has been really supportive of this work, and also just kind of my work throughout my kind of life as an advocate. She and I were actually on committees together at the Mid-Valley Behavioral Care Network a decade or more ago, when I very first started and when I very first learned about peer support and about the consumer survivor ex-patient movement. So huge thank you to Cindy, and everyone else on this list. Really amazing contributors. So thank you. So we put the surveys out, and then in total, between the two surveys, we received 161 responses from every state in orange on this screen, which was an exciting, overwhelming response. Really wonderful to have people from all over the country having responded. And here's the structure of the survey. So there were two surveys. The first was, oh, Dan. Oh, I just see the message that Dan is here. Good. Oh, that's fun. I want to talk about Dan. So Dan Fisher is the president of the National Coalition for Mental Health Recovery, and he was my supervisor and mentor while I was interning with the coalition, and just spent, I don't know how many hours just talking to me about my experience, his experiences, and kind of just how to structure this and how we might all be able to get to a place together where we can make some real change in this area. I also, through the process, was able to do some work around emotional CPR, which I think, and we'll talk about later, I think is really connected to how we kind of dismantle the practice of seclusion and restraint in these institutions. Yeah, thank you, Dan. Dan really has been, is an incredible mentor to me in this work. Good. Okay, so survey structure. So we put out two surveys, one for staff and one for people with lived experience. So the questions were slightly different on the two, but we were asking kind of about the same practices, and just from the two different angles. And, you know, some of you on this call might even know that there are for sure people who have been on both sides of this coin. So there are people who have themselves been restrained or secluded, and then who also have worked in settings where this practice exists. And so some people were able to really fill out both from each perspective. And like I said earlier, we kind of broke the survey up into different settings. And so we looked at schools, and we had 43 responses from schools, psychiatric institutions for youth, and we had 47 responses. Psychiatric institutions for adults, we had the most responses at 71. And then nursing homes, this one was a little low. So later, when we start to look at the data, I just want to have that caveat kind of in everyone's mind that with only 14 responses around nursing homes, some of the numbers look gigantic. Like it might look like 50% or 100% of people said this. And in some of them, it wasn't that many people saying that. So we have to kind of be careful about that data. But it's still important, and the stories are still really important. And so I don't want to take anything away from any experience that anyone described in those settings. I just want to say, like, you know, let's take the numbers with a grain of salt around nursing homes. And then there were 37 people who responded to this category of other. And so here we saw things like jails and prisons, like physical hospitals, you know, like an emergency department, also some kind of interpersonal situations. So maybe a family member or a spouse or a partner. let's see. I think those were kind of the three big categories, and the biggest were kind of medical facilities and jails and prisons. So in the presentation, they're not, I just have a question here about response percent. So these are not percent, these are numbers of people who responded to this portion of each survey. So we combined staff and lived experience, and then 43 people responded saying that they had experience with seclusion and restraint in schools, for example. So first we're going to talk about the staff survey. We'll go through the numbers, and then we'll go through the themes in the staff survey, and then we'll switch over and talk about lived experience, just to kind of give us a little bit of structure for the next section of the presentation. So there were 74 staff who participated. So this is 74 people who have worked in places where seclusion and restraint are used. And you can see the breakout here in each setting. And then here, just again, I'll tell you, nursing homes, for example, there were only 4 nursing home staff who participated in the survey. So we'll just kind of keep that in mind. And again, the largest participation in psychiatric units, especially adult psychiatric units, and then just a couple fewer in youth psychiatric institutions. So the first question that we asked staff was about whether all of the staff in the setting where they worked were trained in laws and policies regarding seclusion and restraint. And so this is the first set of numbers that we're looking at. And I'm mostly just going to focus on the people who said yes to these questions, just to kind of simplify it a little bit. And you can see here, so 55% of staff in schools said that all of the staff had been trained in seclusion and restraint. And seclusion and restraint is happening in our school system. There's actually a decent amount of research around seclusion and restraint in schools. When I was kind of looking into this, probably more than I found in any other setting. Researchers, I think, have been, oh my goodness, you guys, this is the thing that I told you was happening before. That's so funny. Give me just 1 second. Oh, 1 second. I'm actually just going to stop screen sharing for a second so that I can, let me see if that worked. Let's show my, thank you so much for being patient. Just be another second. Nope, I just want you to go away. Okay, moving on. Thanks for your patience. Okay, so only about half of people in schools are, according to staff who work in schools, trained in seclusion and restraint policies and laws. Only 81% of people in youth psychiatric institutions, 63% in adult psychiatric institutions, and then it looks like 100% of the people who responded, who'd worked in nursing homes, said that everyone was trained, and then 40% in those other settings. So I'm using the word only in regards to this question because having myself worked in some psychiatric institutions, I know that they are required to train staff in the laws and policies. And so some of these numbers were really shocking to me. We also asked, in these settings, were staff trained in de-escalation practices? And so de-escalation, I think, in kind of institutions has been touted as this is the thing that you can do to prevent the need for the higher interventions such as seclusion and restraint. And so really the staff are supposed to be trained in these practices as well. And the hope in that world is that the more, kind of the better people are at de-escalation, the fewer people will need that intervention that they still allow. So, you know, kind of some low numbers here. Adult psychiatric units, only 68% of staff say only 68% of people in the institution have been trained in de-escalation. That feels like a concern to me. And then you can see half of people in nursing homes said that all staff were trained, 47% in those other settings like jails and prisons and medical facilities like emergency rooms. So that's interesting. And then we asked staff, have you ever witnessed instances of seclusion or restraint that you perceived as preventable? So these are people who've been trained by the institution where they worked and have witnessed restraint and seclusion. And we said, have you ever seen an instance that was preventable? So in schools, almost everyone said yes, 91%. That's huge. Said, yes, I have seen a child be restrained or secluded when it didn't have to go that way. 76% of people in youth psychiatric institutions, so over 50% across the board, and sometimes much higher than that. So there's that. And then the other thing that I really want to highlight around this is that, look at that. Okay, so look at that bottom bar. So
hey, Patricia, sorry.
Yeah.
So we can't see your slides right now. So
oh, no.
Yeah.
Oh,
no, it's
thank
okay.
you for telling me. Okay.
Yeah, for sure.
Sorry, everyone. Goodness. Let me get back to, let's try again. Okay, let me get out of this. Okay, let's try this. Are you with me?
Perfect. We are with you. Thank you.
Okay. Thank you. Okay, so I'll give you kind of a second to look at this. These are the numbers I was just talking about. And then what I really want to highlight here is that in every setting except for the other setting, 0%, 0 people said that they were unsure whether or not they'd seen instances that were preventable, which just, I think, kind of highlights the divide and really says something about how strong people feel in one camp or the other. So, you know, we had people across the board either say, yes, this could be prevented in these situations that I can think of, or no, I've never seen one that could have been prevented. And so we have far, far more people saying yes, and some people saying no. And then we have no one saying, you know, I'm not sure. Maybe it could have, maybe it couldn't. No one is saying that. People are saying yes or no to this question. And then this slide has kind of the first quote from the survey responses, and there will be several of these throughout the presentation. This person says, I saw instances in which staff chose a hands-on restraint intervention due to their own escalation rather than using de-escalation techniques in which they had been trained. So we also asked staff, have you witnessed instances of staff circumventing or going around policies or laws when initiating seclusion or restraint? So you can see the numbers here, the people who said yes, around half in psychiatric institutions, lower in other settings. This person says, I have seen some staff catch and release with the idea that if they let go before a certain amount of time, they do not have to document the incident as a restraint. This is an example of that someone gave us of staff circumventing policies to initiate these practices. And then next we asked the staff, have you witnessed instances of staff going around policies or laws to prolong instances of seclusion and restraint? So to make it last longer. And here we still had people who were saying yes to this, the highest number in adult psychiatric units, and lower but still present numbers in every other setting. So in every setting, we have staff saying, at least some staff saying, people are going around the laws and policies to put people in restraints or seclusion, and also to make those experiences last longer than they have to, or longer than is even allowed by law or policy. Here are some other examples that people gave us about staff circumventing the rules to either initiate or prolong seclusion and restraint. So these are kind of in categories. Intentional escalation in order to create less work for staff. Staff overstating the danger of the situation to justify the practice. Utilizing chemical restraints to sedate people, including using them off-label. Keeping people longer because of the assumption that they would re-escalate if released when required by policy or law. This one came up quite a few times. People kind of just being preemptive in the way that they didn't allow it to stop. And then giving a medical reason for restraint, because medical restraints have fewer regulations. That one was interesting, and I personally had never seen or heard anything like that, because I haven't really worked in a situation where that's practiced, but that came up several times. It's definitely interesting, and good for us to know. And then this last one, someone asked, what does off-label mean? So my understanding is that it means a drug or a medication that's used in a way other than the way that it was researched and intended. The last one, restraining or secluding as a punitive measure for things like talking too loudly or refusing medication, which I probably don't need to say more about how egregious that is, or any of these are really. Also, just a note that some of this is really heavy. These are people's real experiences in the world, and it really has had a significant impact on people's lives. And so just kind of, I don't know, maybe taking a moment to kind of sit with the weight of that. So next we asked staff, have you seen seclusion or restraint used as a punitive measure? And you can see how many people said yes in each setting. Over half in schools, a third in youth psychiatric institutions, just under 2/3 in adult psychiatric institutions, a quarter of nursing homes, and 60% of those other settings. So a punitive measure means kind of using it as punishment, right? This first person says, for talking loudly, yelling, urination outside of the restroom in a public area, for posturing at staff, refusing medication. And these are quotes from the staff describing times that they have seen seclusion or restraint used punitively. The second person says, I never witnessed actual restraints as a punitive measure, but occasionally staff threatened to restrain someone in a punitive way. This happened more frequently on the child and adolescent units. So we also asked staff, have you, as staff, been negatively impacted by the seclusion and restraint practices in the setting where you worked? And over half of people in every setting across the board said, yes, I have been negatively impacted. And in some, it's upward, I mean, adult psychiatric units, it's 79% of people who took the survey said that they personally had been negatively impacted by this practice, which I think is important for us to recognize moving forward in the work as a way, as kind of like an avenue to partner and to really move toward change together. Because we can see here that these practices can be harmful to everyone involved. And that's not to downplay the experience of being restrained or secluded, because that absolutely, I mean, you'll see later, and I think lots of us know from experience or from the work that we do, that this practice is egregious and trauma-inducing. And if there are staff who agree with that and who say, yes, it's harmful to me too, that may increase, it may be a way to increase our power when advocating for changes. Someone says, wow, is this really happening in schools? Yes, absolutely. And there's lots of research that you can kind of look up, especially there was some research done, I'm not sure about other states, but in Oregon, Disability Rights Oregon looked into this quite a lot. And so there's some numbers on the Disability Rights Oregon website, and you can see that it absolutely disproportionately impacts children with disabilities in schools. So thanks for your comments in the chat. Okay, so those were the kind of yes, no, unsure questions. Oh, Chelsea says Disability Rights Wisconsin has done lots of work around this as well. Yeah, thanks for that, Chelsea. So those were the kind of yes, no, unsure questions that we asked. And then for several of those questions, we also gave people a box where they could type in more information about their experience if they were saying yes to the question. Because we wanted to not just have the numbers, but also hear, like, get more depth. Like, what does that mean to you? And so here are the themes that came out of the staff survey. So the first and most prominent theme was inappropriate staff behavior. So these were staff, remember, or typing the responses. And then the thing that came out of that most often, the theme that was most prominent, was examples and stories of inappropriate staff behavior. So these included things like punishment, people using it preemptively, threats, power struggles and power and control, overreactions, and, you know, examples of staff just being jaded and then that impacting their use of seclusion and restraint. Yes, Chelsea, thank you. Chelsea says there's a very high number of students who are Black, Indigenous, or people of color, and those that have IEPs or 504s that have documented disabilities. Yeah, absolutely. Schools replicate some of the worst punitive punishment matters from a former teacher. Yeah, thank you. It's really important. And it's really important that we all pay attention to it. Yeah, thanks for your comments. So inappropriate staff behavior was the first theme that came out. There were two versions, kind of in general, of people talking about inappropriate staff behavior. And these are two quotes that I think kind of highlight the two versions of that theme. The first one, this person says, there were times when verbal de-escalation skills by staff were not strong enough, or staff were making comments that unintentionally triggered the youth to the point of physical violence. And then the second version, I've seen certain staff use a restraint or seclusion as a means of control and dominance. So people were telling us stories of kind of lack of skill, lack of training, lack of knowledge, lack of just understanding what was happening in the moment. And then there were other stories of staff who were intentionally creating these situations, or the situations arose out of a power struggle. So also just a note about the art in this presentation. So my friend and colleague, Rachel Kitterman, created the art pieces that you'll see in the presentation for this work. And so just a huge thank you to her. She's an incredible artist, and you can see there's a pretty big range in her artistic ability. So the second theme that we saw from staff was around poor working conditions. People said that reduction is possible with good leadership. The other side of that coin is that people were saying, you know, leadership matters. And when there's leadership that's not supportive to reducing this practice, that it can get pretty rampant. People talked about a lack of training, about staff fear, which created kind of a culture of fear. And then people were saying that that would then lead to more instances of seclusion and restraint. And then general kind of poor working conditions, staff being burnt out, fear of retaliation. So staff who wanted to speak out were afraid of what would happen to their job or to them legally even. And then the next theme that we saw from staff was around trauma. People talking about the staff not being trauma informed, vicarious trauma, and then it also being traumatizing and re-traumatizing for the people who were being secluded and restrained, and then traumatic for staff as well. And then we also have this theme of morally wrong. So people in their comments were saying things that described that this practice creates mistrust, it makes things worse, it's harmful, it increases reactivity. And so this theme came up 38 times from staff, which maybe just keep this one in mind for later when we talk about the lived experience responses. This person says it was pure and simple abuse and torture that will intensify earlier instances of trauma they have suffered and cause them to be more fearful and distressed in the future, possibly for their whole lives. And so this was a staff quote. One thing that we saw when kind of the work group that was putting together the themes was going, there was something interesting that a couple of people noticed where the staff responses were more, what's the best way to say this? There was more distance between the staff responding and the action that was happening. And so sometimes that was because it sounded like a staff member was describing something that another staff was doing, or that in general other staff had done. Whereas in the lived experience survey, the responses are very personal. They're very like, this is how I felt, this is what happened to me, this is how it impacted me. And so that's just interesting. I mean, part of that maybe is the way that the questions were worded, but also just the difference in how personal this is to people in those two different roles. So right now we have an option to take a little bit of a break. Yeah, Jack says providers are traumatized in our system too, right? Yeah. Yeah, and you can see that in the responses from staff, especially in the response where people were talking about it having a negative impact on them. Yeah, thanks. So a little bit of a break. Let's see, it's 9:50. And I'd like people to have an opportunity to come back and share their experiences. So let's take kind of a quick 5 minutes if you need something, and then I'll just get started again soon after that. Mhm.
Hey, Tricia, can you hear me?
Was someone asking a question? Okay. I just admitted someone. If you can hear me, we're just taking a tiny little break and we'll be back in less than a minute. Thanks. Okay, welcome back, everyone. I hope that that was helpful, taking a little break in the middle of this. And then, yeah, we will get going again. Just pausing a second for people to get back in if they had left. So here we're going to talk about the themes. So we already went over the staff themes, and some of the themes definitely overlap. And so these themes, morally wrong and makes things worse, which I told you to kind of remember for later, inappropriate staff behavior, and trauma showed up in both surveys, staff and people with lived experience. The staff survey, we also saw poor working conditions as a theme. And then in the lived experience survey, we saw connection, compassion, and talk to me, and then training and oversight needed / changes possible. So we'll hear more about those in a while, but I wanted to show you kind of the place that they intersect. So we had 87 participants in the lived experience survey, 23 from schools, youth psychiatric institutions 21, 49 from adult psychiatric institutions, that was the highest again, 9 people from nursing homes, and then 21 from other settings. So we asked people with lived experience, people who had themselves been secluded or restrained, had you not been secluded or restrained, would you have hurt yourself or someone else? And the reason that we ask this question is because often this is the language in the laws that sort of allow these practices. So one of these has to be present, or the imminent, the like right now danger of one of these things happening has to be present in order to justify the practice of seclusion or restraint. And you can see very few of the people who had been restrained or secluded say that if that hadn't happened, they were going to hurt someone else or themselves. I mean, the highest number we have here is 1/4. So just taking that as an example, if only 1/4 of the people who are being restrained would have hurt someone if that hadn't taken place, then 75% of the time with these numbers, we're doing something wrong. And maybe the more provocative thing to say is we're doing something illegal. Now, of course, there's a lot more to this, but I think these low numbers are really important to see here. 0% of people in other settings, in jails and prisons, in residential settings, in medical settings, everyone who'd been restrained or secluded in those settings said that they weren't going to hurt anyone. We also asked people with lived experience, do you feel that the incident that you experienced could have been prevented? And most people said yes. Really, the vast majority of people said yes, this could have been prevented. This person says, the person can be talked to. In many cases, my behavior was out of fear of what was happening. We also asked, so I wanted to do kind of a side-by-side here. So we'll go back to something that we had asked the staff. So with staff, we asked, have you witnessed instances that could have been prevented? And people with lived experience, we said, do you feel that the incident that happened to you could have been prevented? So I just want to show the difference here. Mostly I pulled out adult psychiatric units, partially because this is the biggest discrepancy, the biggest difference, but also partially because we had the most responses from people in this setting on both sides. So 68% of staff said, yes, I've seen instances that could have been prevented. And 91% of people with lived experience said, the thing that happened to me could have been prevented. And the same, 32% said no. 32% of the staff said no, I've never seen any instance that could have been prevented. But 0%, 0 people with lived experience said that what happened to them could not have been prevented. So this is a huge discrepancy, and Oh, and then this quote, this person says, it makes people less likely to trust other people and makes recovery and healing harder to come to. So let's talk about the themes that we found in the lived experience survey. So again, the very top of the list with the most instances of occurring throughout the survey, we saw inappropriate staff behavior. The biggest one was people saying staff did nothing helpful. You'll see more about that later. We asked kind of a specific question about that, and you'll see some of those responses. Rudy says they come from a country where this is more evident. Yeah, thanks, Rudy. I wonder, I'd be interested to hear more about that later. Yeah. So inappropriate staff behavior in the lived experience survey came up 167 times. People said nothing helpful. They said poor staff behavior. There was staff aggression. They talked about control and neglect. And then the threat of punishment, power, abuse, lots of stories of abuse, and it being used as a punitive measure. Here's more, like I promised on this. So this was an open-ended question, and 37% of the people who responded to this open-ended question about what was helpful typed in the words nothing or not a thing in response to this question. When people did respond with something that was helpful, it was some of these things: tending to their injuries, access to medical treatment, not acting afraid, allowing space, giving legal assistance, just the act of being understanding, and then providing practical things like snacks, books, and entertainment. The second theme that came out, the second most common theme, was this theme that I said we would refer back to about morally wrong or makes things worse. So with the staff, I think we saw this 37 or 38 times. In the experience survey, this came up 145 times. People talked about the practice being morally wrong. They talked about fear, the loss of respect or the loss of trust, that it makes things worse, that it leads to people avoiding mental health treatment altogether, that it's inhumane, dehumanizing, and shouldn't be a practice. Here are some quotes. This person says, "I'm afraid to talk to mental health professionals for fear I will be locked up." Someone else says, "I've had times when I needed intense therapy or more medication. I stay home rather than allowing myself to be institutionalized and risk being held and abused." And then here's what I was telling you earlier. So this came up 38 times in the staff survey, 145 in the lived experience survey. These practices would in most cases be a crime if committed by anyone outside of an institution. Carly is talking about students of color being more likely to receive a diagnosis of oppositional defiance disorder, which there's research behind, when partaking in similar behaviors as their white peers who do not get that diagnosis. Yeah, it's true. And then we point to a high suicidality correlation with people with that diagnosis. Yeah. And point to that diagnosis instead of to the racism and unmet needs that they've experienced, as well as how they get treated once they have the diagnosis. Yeah, absolutely. Thank you for bringing that up. Yeah, and I think that work, the work of like racial justice, needs to be at the forefront of our minds as we're talking about restraint and seclusion and coercive treatments, and just kind of the domino of things that happen to people disproportionately. Yeah, thank you for bringing that up. So the next theme that we saw was this theme of connection, compassion, and talk to me. So this was people saying, just I kind of imagine people saying, like, it's not that hard. Like, just talk to me, right? And then people also brought up the theme of trauma again here, and especially people with lived experience talked about these practices having a lasting impact. And many people described the onset of PTSD related to their experience of being secluded or restrained in an institution. This person says, there was no one speaking. I was physically thrown against the wall, thrown to the floor. 4 men sat on top of me. The brazen lack of care for my physical well-being shows how little my life meant to those in charge of my life. This is a really powerful quote. Really, really powerful. The next theme that came out was of training and oversight needed. So people were saying, we need supervision, we need oversight, investigations, de-escalation skills, that there aren't enough staff, and that there are support people needed as well. And then proactive and preventative approaches. And people saying, we know alternatives exist. And ultimately in this one, there was kind of a feeling of change is possible. This person says, in other situations, when someone took the time to try to understand what was going on and why I was so upset, rather than rushing to take my power away, that helped. So again, the artist Rachel Kitterman did this piece, and the artist depicted in this piece, her name is Judith Scott. And she's a person who spent the majority of her life institutionalized and was a brilliant artist. And so I just wanted to draw your attention to that. And maybe if you have a little time, look up Judith Scott, the artist. So, the next thing that I want to talk about here is this idea that seclusion restraint might be necessary or helpful. And I wanted to bring this up because it always comes up in these conversations. There is, yeah, sorry about my dog. Well, it's actually my dad's dog. It's okay. There's just someone right outside the gate checking their mail or something. Sorry. Yes, he needs lots of treats. Yeah. Yes. Very good guard dog. It's okay. Come on, babe. Just doing their job. Oh, okay. So I want to address this idea of the practice being necessary or helpful on occasion because it comes up. In this survey, the staff only brought this up 26 times with all of the staff that participated and all of the times that staff were given opportunities to type in responses. So only 26 times. And when people were bringing it up, they were talking about pretty extreme scenarios. And then in contrast to what people are saying in the rest of the presentation, that doesn't address the vast majority, the huge percent, sometimes over 90% of times that people were saying that it was happening at a time when it wasn't necessary. So I just want to kind of say that. And even when people were bringing this up, they were saying things like, well, yeah, it's bad sometimes, but debriefing helps. So that is interesting. In the lived experience survey, it only came up a total of 12 times. And it was things like this. So people were kind of, one person one time said, I know the staff were following the rules. One person one person said, you know, it kept me safe this time and it kind of woke me up. That person was also, just for a little context, talking about having been restrained or secluded in an emergency room while they were intoxicated. And so that person kind of talked about that whole experience leading to reevaluating decisions around substance use. And I kind of just wanted to put some of this out here to show that, yes, it did technically come up, but only technically. And it's worth also at the same time talking about the giant swath of people who said that this was preventable and didn't need to happen. And then, as people have been talking about in the chat, which I really appreciate that this came up before we even got to it, I want to talk a little bit about the importance of racial justice in this work. So we can see, well, I'll talk from in my experience and also in the adjacent data. There's data and experiences that demonstrate the need for work in this area. So we know that racial disparities exist in schools around suspension, expulsion. We know that disparities exist in jail and prison sentences and in police violence. And then I also just want to tell you that in my experience, having worked in a couple of institutions, the most egregious acts of restraint that I have ever seen were perpetuated against Black men. So that's just one person and an anecdote, but I will tell you that these things together are enough for me to be confident that future research should include questions about racial bias, and that when we get to the recommendations, when we're requesting data collection in the name of transparency from legislators, we request that they collect demographics data that includes race in order to better understand and address the impact of systemic racism on restraint and seclusion. Oregon uses something called the Real D framework, which you can look up when you have a little more time. And I also want to say we shouldn't wait in before we start advocating for racial justice and reconciliation around seclusion and restraint in our institutions. So here are the recommendations. We have policy recommendations, including creating a state and federal restraint and seclusion oversight committee that include 2 or more people with lived experience and that give communities the authority to influence change. Next, track all incidences of restraint and seclusion and make the information available to the public. And then include demographics data using the Real D framework in order to identify and address systemic oppression in restraint and seclusion practices based on race, ethnicity, age, language, or disability status. And then to create statewide plans to reduce restraint and seclusion. And then at the practice level, we're suggesting adopting NASBYD's 6 core strategies to reduce seclusion and restraint use. And you'll have access to all of these links and things in the handouts that go along with this presentation. We also recommend transforming seclusion rooms into comfort rooms, and you can see some examples of that in this link. And then requiring universal training in trauma-informed care, compassionate communication, and de-escalation, separate from restraint and seclusion trainings. Because the other thing that we know and that we learned is that most of the de-escalation that staff are trained in is like the first section of what is ultimately a restraint and seclusion training. And so kind of separating those and giving some good in-depth training around de-escalation. And then improving working conditions for employees, including making sure that there's adequate staffing, there's increased supervision, and that staff have access to ongoing coaching on the skills that are learned in these trainings. And then the other recommendation is to inform consumers/patients and their family members of the laws and organizational policies that govern the use of this practice in a written and verbal form in their preferred language before admission, so that everyone knows their rights. And then on the other side, ensuring that there's access to legal aid and patients' rights advocates when a consumer or patient feels that these policies or laws have been violated. So rather than a breakout session, I'd like to just kind of hear your responses. So maybe we'll maybe you all can just let us know your kind of responses to all of this. I'm going to stop sharing the screen after I go through the questions, but I'd love to hear what moved you about these results. When you present the information to others, what will you emphasize, and how will you go about sharing what you learned here? And then how will you go about contacting your legislators or other people who can take action on these practices? And what else can you do to move the recommendations forward in your organization, your state, or nationally? So I'm going to stop sharing the screen, and I would love to hear from everyone. Oh, you know what? And Dan is telling me that there might be a little mistake in here. The 6 core strategies are actually from NASMHPD. So sorry about that. I apologize, and we'll make sure that the link is correct. So I would love to hear your thoughts. Feel free to.
I have something to say, and that is that
Great.
every state has a disability law center. They're called different things, but every state has one, and they have a federal statute that allows them to go into institutions and check on people who have been restrained, who are being restrained. A family member or themselves could call them and say, I'm being abused or whatever, and they will come out and check on it. That's how I got free.
Thank you. Thank you, Nancy. I appreciate it. It's a really important resource.
I think one of the biggest things that impacts me is the number of staff who found that, in their opinion, it could have been avoidable. And then what is their recourse in that moment? I know I was working in an institution. I worked in the school district and in an institution where, you know, you're the new kid on the block. And we just saw it with George Floyd. You got the 2 new cops who are under his training, Derek Chauvin's training, watching this restraint and saying, are you sure we're supposed to be doing that? And I've been in that exact scenario where they're restraining a child, and I'm thinking, have we gone too far? Are we jumping the gun? We're going hands-on prematurely before we've even de-escalated or communicated. And you're a new trainee, so you're just kind of waiting by the wayside while they take action with aggressive behavior, you know? And so we need people to be able to speak up as fellow employees and talk to their employees during escalation. Maybe we have a tactic that we can intervene and stop them and say, it appears that you've become escalated now, so I'm going to take over, and we just interject and dismiss the other employee.
Yeah. I think that is especially important. It's especially important, period. I also have a story that I told at a Peerpocalypse a few years ago, being a new staff person in an institution and questioning something that was happening and having the experience of being really dismissed about it. So I think it's important too for staff who like maybe are not the brand new person, right? To continue to stay in this fight and understand that change is possible. I think we really have to address like the way that people connect with one another. So I saw Dan in the chat, and earlier I had mentioned ECPR. I think I think without that ability to really connect on a human level, staff to staff, but also like person receiving services to person receiving services, person receiving services to staff, like take all of those hats off and just be human with one another, I think can go a long way in reminding us all that we are here in like in connection with one another. I mean, it's one strategy, and I think it's an important one, but really, how do we address, like, I think to your point, how do we address the culture that starts to exist in these institutions?
So Tricia, as a person that works in a county system, I think sometimes it's kind of hard as a person with lived experience to, sometimes I feel like I'm the only one that speaks up when something isn't the way it's supposed to be. And at times I know that that has been seen as problematic by others, and it feels really lonely. I also think that it's super hard when I am doing my work as an innovative agitator in the system to not feel like I get tired sometimes. I get exhausted from trying to do what's best for people like myself. And and I think in a lot of ways it's good for people with lived experience to be in the system, and in a lot of ways I think it's re-traumatizing, and it's difficult, and it's hard, and it's not something that we speak about. We talk about the good things about having peers in the system, and at the same time I think it's really hard not to be pulled into the system and co-opted by the system, and then to see things happen to the people who you are, and then like how do you walk in between those two places of being a person with lived experience and also being a person who's working in the system now? I think that's a really important thing.
I think the power differential is really important. I see people in the chat kind of commenting in response to what you're saying about power. I think that's really important. I think, you know, Cindy, but for a long time I've talked about the system being this like giant wheel, and then someone comes in, and then the next thing you know, like we're all just on this giant wheel together, because it's so there are so many forces at play regarding power. And so I see people talking about excuse me, I see people talking about in the chat like the importance of outside work and more accountability, right, from outside of those systems and outside of those power dynamics between people within an institution.
I agree. I think it, you know, I think it's really hard to be in a system when in a lot of ways you rely on other people to be helpful to you when things kind of are rough, and you, it's just really hard. And I think I'm really appreciative of the work you've done around seclusion and restraints, because it's not something that we discuss very much. And also having peers moving into the system and having to be a part of that, or having to like figure out how to be someone who stands up and says, I'm not going to be a part of that. How do you do that in a way where you maintain your dignity and at the same time maintain your professionalism as seen by those around you? Because I've had numerous times when I have done things and people have attributed that to my having my mental health symptoms being active. It's so disheartening at times.
I think that with that, I think that an important thing to acknowledge is, I mentioned in the comments, the Stanford prison experiment. I think that we're all susceptible to becoming agitated and reactionary. I think that, you know, Brene Brown talks a lot about the vulnerability, and if we can get our staff in meetings and vulnerably share what they were feeling in this power dynamic with this client, and talking about where they can do better, where they can improve, and taking the shame away. Because when we're ashamed of our behavior, when we've abused a client, then we hide it and we defend it and we get more aggressive, and we have to keep defending these egregious actions. But when we remove the shame and we get vulnerable and talk about where our shortcomings are and when we fail, then we can start to change. We have to expose it for what it is. We're all susceptible to becoming over agitated in these high tense situations.
Yeah. Thanks for that perspective, Kayla. I can like feel in my body the weight of that line of thinking, even, right? It's hard to even go down that path, I think, even from the outside. And so I just want to appreciate how hard that work is and how important it is.
Patricia? Thank you very much. I think it really was excellent. I just wanted to underline the power issue, because I worked for 3 years on an inpatient unit as a psychiatrist with lived experience. I was open about my lived experience. And when seclusion or restraint happened, it was always when I wasn't there. It was, they never did it in front of me. And because they knew my views on it. And also I noticed that the staff just didn't really get to know the patients. They were either afraid of them, or it was stigma and discrimination. And they criticized me for spending time talking to people even. And I think just getting to know people makes such a big difference in this, in the environment, because it is very charged. People are there voluntarily. People have so much power over them. It's very, so I think there needs to be outside evaluation, really. And I don't know, there are evaluators, like in Pennsylvania, they have evaluation teams, but I don't think they evaluate seclusion and restraint.
Yeah, I haven't really been able to find anything outside of small, maybe an institution or an outpatient system tracks it somehow, but I haven't seen any. I mean, that's why one of the biggest recommendations is that we create oversight committees.
Well,
They're at the state and national level, because I don't even think we're counting it right now. Like, I don't even think I can go somewhere and find out how many people in the US have been restrained in the last year, which I mean, it's so hidden. There's laws that govern it, but we just don't have the rest of the system in place for accountability around it. I wanted, before we completely run out of time, because there's only about a minute left, a few people in the chat are asking where to find some of the resources that I talked about. So Katie, correct me if I'm wrong, but I believe that attached to this presentation, there are 2 PDFs, and one of them is like a synopsis, and then the recommendations. And then the second one is that same information, except it's got an additional first page that's a form letter that you can send to legislators or policymakers. So those 2 exist. The letter, probably best to copy and paste it into an email browser so that you can change it easily, because I offered it in a PDF form so that everyone could access it.
Yeah, that's correct. So if you're using the app, you can go on the workshop for this time, and then at the bottom of the workshop it'll have other resources and you can access it there. Alternatively, if you're not using the app, we'll be mailing or emailing out the resources with the CEUs.
Yeah, thank you. And I also just want to say, like, a huge thank you to everyone for participating in this workshop and for contributing in the chat and your comments. I really appreciate the energy around this topic. And I'm available. Let me see, I will type my email in here right now, pgodsey@pdx.edu. And so feel free to contact me after if you want to talk about any of this more, or if you have other ideas. And then, you know, please, please, please feel more than free to share the information with anyone and everyone. Yeah, thanks a lot.
Thank you so much, Patricia. I'm going to go ahead and end the session right now, but that was amazing. Thank you.
Thank you. Thanks, everyone.
Bye.